Good morning, everybody. Welcome to the start of day 2. So I'd like to introduce Adrian again, Adrian Raine, and just mention he's going to give us a little summary of what went on yesterday. And I just want to mention something about Adrian before he comes up here. There's so much to say about him, and I curtailed it yesterday, but so that in the thought that you would rather hear him talk than me talk about him. Dr. Raine has been instrumental in the American Society of Criminology in encouraging a biopsychosocial perspective to the investigation of antisocial behavior, in which the end goal is to integrate these elements of the social elements, psychological and neurobiological. To this end, he has worked to establish a division of the American Society of Criminology, the Biopsychosocial Division, and he was the first chair of that when it started a couple of years ago. So, without further ado, Professor Raine.
Right, good morning, everyone. So my enviable job is to summarize everything that happened yesterday, which I was panicking about a little bit, but I'll try and do the best I can over the next 15 minutes, just to put back in our minds what happened yesterday before it's all distinctly forgotten. Let me see, I'll start first by talking about the things that James was alluding to. And I want to start off with the different forms of aggression that James was talking about. And he talked about reactive aggression. And just to really put that, firmly into the picture. Let's see if I can get that. He dropped his keys.
I love it.
Oh!
I should have guessed. Oh my God, that was startling.
I like that one. Feisty. Yeah. There you go with a scary stranger. We get back to PowerPoint now. So I can only think the reason why that it elicited the really what we call defensive aggression is because he had a little child with him. Maybe, I'm trying to salvage him from, gross psychopathology. But I think I'm always fascinated by James' talk, wherever I hear it. And I think he's making an important point that, it's not one size fits all. There are different forms of violence. And I think I really liked in his talk how he brought to the fore that concept of reactive aggression. And, for sure you can say, well, look, the correlations between reactive aggression and proactive aggression are not trivial. They're around 0.5, 0.6, something like that. But I don't think we should, because of that, throw out the baby with the bathwater, because let's think of other concepts which are correlated like that. So let's take verbal IQ and performance IQ. You would say, well, they are different. There's different manifestations of those forms of cognitive functioning, but they're correlating at the same level as proactive and reactive aggression. And I think James was really talking about, for sure there's going to be different neural systems underlying these two forms of aggression, and presumably we're going to end up with having to formulate different treatments for these two forms of aggression. James very appropriately pulled me up when I talked about enlargement of the striatum and Buchholz's work on enhanced dopamine release to rewards in psychopathic individuals. And also Ted Buchanan as well pulled up a lot of data saying, look, if you look at ADHD kids, externalizing behaviors, it's not that direction. In kids, what we've got are like reduced dopamine release to rewards reduce striatal volume. So yeah, I for sure have to go back to my data and double check all this. And I've got to step back and think, well, maybe our data are just wrong there. And I try to link striatal enlargements to the reason why antisocial violent individuals seek out rewards. Maybe that's not an appropriate approach. So I appreciate, James, you give me caution in where I was coming from. Third point on James's talk, he talked about empathy. That was a key point at the beginning of James' talk. And that gets me thinking, of course, to the fact that we do have gender differences in empathy, at least in self-reports. At least in self-reports, the effect size there can be as high as 0.62. So given that we've got the gender difference in empathy, at least with self-reports, is that one of the reasons why males are so much more violent than females? Because they are more lacking in empathy, a risk factor for violent behavior. You know, most of all, actually, in James's talk, I really liked something he threw in at the end where he got to the heart of Paul's question, why are males more violent? And yes, he invoked testosterone, but of course talking about the fact that, well, that's true of all males. But then he brought up this interesting data talking about how perhaps our response, the male response to that spurt in testosterone at different times in the day or in the weeks may be a function about their background. And if the person's social background is one of aggressive behavior, he argued that they're the ones more likely to respond to a spurt in testosterone with an aggressive response. So thank you very much, James, for your really excellent talk. Come on to Ted, talking about ontogenetic processes. And if you're not sure what ontogenetic really means, you're not the only one. I don't know what it means. I looked it up yesterday, and it's really early development, really starting early in life. And you might remember Ted's really interesting opening slide there on diabetes mellitus as a fascinating model for us to think about. Ted essentially was talking about a neurodevelopmental model of male violence, really, which starts off with ADHD. So I'm just trying to remind you what Ted was trying to get at. And he talked about that cascade of development from ADHD to oppositional defiant to conduct disorder to antisocial personality violence later on in life. He also talked about the delayed maturation hypothesis. That stuck out in my mind. You might recall that Ted was arguing for the fact that most of us with increasing age, gray matter decreases, white matter increases. And he's arguing for the antisocial spectrum that you get exactly the opposite. I was a bit intrigued by that from a personal standpoint because I was wondering, could that process explain why some people who study children or adolescents find striatal reductions, whereas me studying adults find striatal enlargement? That once you get to adulthood, there's a lack of neural pruning, which transforms reduced striatal volume into higher striatal volume. But on the other hand, I'm not sure that that is the right sort of hypothesis, because if you have a lack of neural pruning in the antisocial violence spectrum, then in adulthood, we should find excessive neural matter, and we tend to find the opposite to that. So just a word of caution, I think, on that delayed maturation hypothesis. And I think James has perspectives on that, which he'll keep mum to at the moment, I think. What I was fascinated by with Ted is this question of, are we really waiting too long to intervene? Are we really waiting too long to intervene? And I think he's arguing we've got to start really early in that neurodevelopmental cascade leading up to violent behavior. And I think that's a critically important point for all of us to focus on in the next 2 days, about how early should we be starting to intervene here. Yes, Danny, thank you very much, because Danny sent me a couple of slides. Thank you very much, Danny, at my request. Bit of text here, but I think that what I want to highlight here is this part over here, antisocial violent behavior. And I really like Danny's approach. It's classic. You start, first of all, by finding out what are the risk factors. And Danny says the best predictors here are low income, minority status. We can't do a lot about that, can we? But there are others. Parenting, child emotion regulation, conduct problems before age 3. And so the strategy that Danny was emphasizing, find out what the predictors are, what the presumed etiological agents are, and then moving into this second point down here at the bottom here, let's target these behaviors in early childhood, the behaviors that's malleable. And I think, Danny, you're not going to give up on trying to change poverty. And in the long term, we can change minority status. But in the meantime, let's look at those malleable risk factors. This is another slide that Danny said. I want to highlight, Danny is saying we need to start family checkups, the prevention intervention, in a critical developmental transition. It's really got to come really early in life, as early as age 2 to 3 there. That's the critical neurodevelopment. And I think you shared a lot with Ted, I think, in your perspective on really starting early on in life. So I might say, yeah, we must, but how exactly? Danny's leading to that. And I think the question is, do we target a subgroup? And I think, Danny, that's going to be your goal, because the other approach, of course, is to try and roll out interventions across the board, which is a really, really difficult thing to do. But we've got David Olds going to be coming up, I think, tomorrow, talking about his intervention and how he got his experimental intervention rolled out into practice. Because getting things into practice, I think, is the difficult issue. The other point Danny raised, which I was really struck on, is this. And I really applaud Danny for saying in his intervention, it only worked for less than half of the population. It takes a lot of courage, Danny, to say, I've got this intervention, it works, but you know what? For half the people, Danny's words were, it was a waste of time. Hopefully not exactly a waste of time, but I think, you know, we have to begin to think, as Danny is doing now, who the intervention's working for, who the intervention is not working for, and let's titrate the intervention and be more selective in who we give the intervention to. Okay, so yeah, Danny, you know, I want to keep on. Danny talked about changing the light bulb. You know, he says, remember, how many therapists does it take to change a light bulb? He said, it only takes one, but you need but the light bulb has to want to change. Danny says, let's change want to change to be motivated to change. And it's true. Light bulb needs to be motivated. But some of those light bulbs, once you've taken it out, how do you get the other light bulb in? Because I think taking out old habits and bringing in new habits, that's difficult, isn't it? We can be motivated to change, but can we do it? I'm overweight. I've got 5 or 6 pounds I've been desperately trying to lose. You may not think it, but honestly, it's sitting right there. And blow me down, I can't do it. I'm motivated. My trousers get tight. I feel low self-esteem. And I know what to do. Just don't put food in my mouth. But I can't do it. I just can't do it. So the big challenge is we may be motivated to change, but how do you get them to change? At least Danny has been successful in being able to do that. But it's a heck of a tall order to get people to change. Danny's words, hey, aggression comes before ADHD. And I think you're alluding back to Ted's talk where Ted started with ADHD. Danny's reminding us something comes before ADHD, and it's aggression. And I don't know where Richard Tremblay is in the audience today, but with Richard, I always remember hearing him in France, 2005, and he says, does violence peak at 19 years? No, it peaks at 19 months or 18 months. And he's stuck in my mind the whole idea that the key peak in violent assaults is actually 18 months of age. So aggression really does come early. And so maybe not just ADHD, but we have to turn to aggression. And what I liked about Danny's talk is improvements were mediated by the ability to improve parenting and depression at age 2 to 3. This is great. You've got a treatment that works, but let's find out what moderates the treatment. What factors moderate the treatment? That's going to put us on to better treatment interventions. And again, targeting. Okay, so what about my talk, my parting shot? So I spoke for 45 minutes. I want you to forget 44 minutes of those 45 minutes entirely. 1 minute I want you to remember about, just one thing. It was one slide. It was the slide on the omega-3 randomized control trial from Mauritius. Right, I want you just to remember now this slide. It's all you've got to remember from my talk. Brain imaging research. There's one thing we can conclude from brain imaging research, and that is if you've got a bad brain, that links to bad behavior. Bad brain, bad behavior. I will stake my life on that fact. I'm prepared to be hung, drawn, and quartered if that statement is not correct. That's point one. Point two, a basic neuroscience finding, omega-3 is critical for brain structure and function. That's true. That's a fact. And I'm not backing down from that fact. You know, you can boil me in oil if that statement is not correct. Point three, experimental clinical neuroscience findings, omega-3 does reduce aggressive behavior. Now, if that's not true, I mean, well, you've done most of what you can with me, but if that's not true, you can take my wife and kids and hang, draw, and quarter them and boil them in oil and tar and feather them, whatever's left of the bits of them. Why do I say that? Well, what I didn't mention yesterday, I reported one randomized controlled trial, one that showed that omega-3 to some extent reduces aggression. What I did not mention is that 2 years ago, Gadgets and Beaver, meta-analysis on omega-3 on aggression. 30 studies looking at omega-3 or not, does it change aggression? Overall, across the board in those 30 studies, the overall effect size is 0.24. Omega-3 reduces aggressive behavior. It's not a big effect size. Combine that with something I did not say yesterday. I talked about one randomized controlled trial that I've done. I've actually done 6. I've talked about that. In 5 out of the 6 randomized controlled trials I've done, specifically on omega-3, it's successful in reducing antisocial and aggressive behavior in 5 out of those 6 trials. So based on that, what's the implication? I think you have to consider, omega-3 as a supplementation to reduce aggressive behavior. Because unless you consider that, my question to you is, well, how many more randomized controlled trials are you waiting for? I mean, after 30 in that meta-analysis, after the 5 out of the 6 I've done, I just don't know what you want for change. I don't know what you want for change. Okay, so those are the speakers, but last but by no means least, let's take the audience. I need to summarize the audience yesterday. You were a really great audience yesterday. You were really very attentive, very focused and everything. And I think I love the questions that you raised, some really interesting questions. One of them, sort of a pretty subjective question. It struck me, it probably shouldn't strike me, but somebody just over here somewhere towards the end on Danny's talk said, you know, well, okay, you're doing these interventions, but I'm dealing with people with really basic needs of impoverished families, people who don't have food on the table, people with not enough money for lighting and heating. And I sat over there and I thought, as a scientist, I just don't think of that. I think about what can we do experimentally in a laboratory to change behavior, and I'm not having to do what you have to do in the real world. And I think this is a real challenge of whatever interventions we develop, we must make them tractable and easy to implement. And I think that's a bit of a challenge for all of us. I was honestly struck by that. Then we've got this one. I mean, this is, Jay Belsky. You always ask difficult questions, Jay. And, but this is a really good question. I mean, Jay was asking, okay, you're doing this fancy neuroscience stuff, but come on, how's it going to lead to new insights? And I've been reflecting on this more and more, and you're right, Jay. Let me criticize the finding I gave. I talked about psychopaths who lack emotion. And okay, so what do we find? We brain scan them, and guess what? we find they've got a shrunken amygdala. And here's me yesterday saying, yes, so psychopaths have poor emotion functioning. And Jay's going to say to me, what the fudge? You know, we've known that for like 150 years. Yeah, psychopaths have poor emotion. Where are you going to take this finding on the amygdala, and how are you, Raine, going to develop new interventions that we've never heard about before, targeted on that brain finding, and how are you going to make a difference? And that's a big question. That's a really challenging question. Lastly, the question, I was trying to get to sleep last night, couldn't get to sleep, and it was a question that haunted me the whole day, and it's, what about the roles of bipolar disorder and depression? You know, what about that? And, you know, we had dinner last night, right? We were talking about this, and it's an important issue because, again, we're at this meeting, we're talking about let's change violence, but I'm forgetting the whole issue of comorbidity, that a number of you are dealing with people in prisons with bipolar disorder. And your question to me is, well, what approach do we take with them? What do we approach with individuals with depression and also aggressive behavior? And I think that's a critical question. As well as thinking about what interventions work for violence, let's think about what interventions work for all the comorbid conditions that go along with violence, because maybe a bipolar patient is violent for reasons to do with their bipolar disorder, same with depression. And that the success with those individuals will require a different approach to the type of focused interventions that we're talking about here in relation to aggression and violence. Okay, Paul, so actually, I think I've gobbled up all the time. Yeah, I'm sorry about that.